It is a real pleasure for me to be here at Queen Margaret University. This is an institution whose School of Health Sciences has developed a very strong and a thoroughly well-deserved international reputation for teaching and research. And the 3,000 people who are studying at the school today will, I have no doubt, I've spoken to some already this morning, go on to make a major contribution to the health and well-being of people here in Scotland, but also, I'm sure, around the world as well. So this is an ideal venue, perhaps this is the ideal venue to speak about the future of health and care services in Scotland. And there's no doubt whatsoever in my mind that this, the second decade of the 21st century, is a really pivotal moment for healthcare and healthcare systems, not just in Scotland, but right around the world. An ageing population, a shift to more multidisciplinary working, and of course rapid advances in research and technology, to cite just some of the trends we currently see, present challenges but also tremendous opportunities that the founders of the National Health Service could scarcely have imagined all these years ago. And it's the decisions we take today on research, on how our National Health Service is organised, on the relationship between and the investments we make in social, community, primary and secondary care, and of course on the education and training of the health and social care workforce of the future that will determine how well our health and care services respond to these challenges and opportunities. And as First Minister, and I speak on behalf of the Health Secretary here today, we're determined that we take the decisions, including decisions that sometimes will be tough decisions, to make sure that our health and care services are fit not just for the here and now, but are fit for the future and for future generations as well. Indeed, today is one of a series of Scottish Government events focused very firmly on the future of health and social care services. At the start of the week, on Monday, I visited the Stratified Medicine Centre at the new Queen Elizabeth University Hospital in Glasgow. And that centre assesses data to find out how people with different genetic makeups will respond to different treatments. And it's a fantastic example of how new technology is transforming our ability, or your ability, to treat patients. And the purpose of my visit on Monday was to announce £4 million of funding to support research into precision medicine, medicine that is specifically tailored to meet the specific needs and characteristics of individual patients. Precision medicine is a field which has, often we use these kind of words in an exaggerated way, but this is no exaggeration. It's a field which has the potential to transform healthcare in the years ahead. It will have enormous benefits for individuals and for the health service alike. It can reduce the risk of wasteful and ineffective prescriptions that do very little to help patients, but also provide better and more effective personalised treatments to patients that are tailored to their genetic makeup and the particular characteristics of their disease. And Scotland, due in part to our size, the strength of the collaborations between our NHS, our universities and industry, the skills of our clinicians, and the wealth of comprehensive joined-up patient data that we have access to, is now ideally placed to be not just a world leader, but perhaps the world leader in the development and commercialisation of precision medicine. So the funding that I announced on Monday will help to build the infrastructure, the precision medicine ecosystem, as the clinicians call it, that we need to seize that big opportunity. Now, that announcement that I made on Monday is not the biggest health investment I've ever announced, far from it, but I think it could well be one of the most significant health investments that I've ever announced. And next week, we'll also be launching our new national clinical strategy, which will set out how we will deliver health and care services which meet people's needs in the years and decades ahead. And all of this, of course, is happening at the time of our national conversation on a healthier Scotland. The Scottish Government has heard from more than 17,000 people at over 150 events across the country on how we can build a healthier, a happier and a fairer country. So today's an appropriate time to reflect more broadly on the health service in Scotland, on what's been achieved in recent years, and on how much more we need to do in the years ahead. And in my remarks, for all the complexity involved in delivering modern health and care services, and it is a complex business, the basic argument I'm going to make is actually a very simple one, and it's this: care should always be delivered as locally to the person receiving the care as possible. In fact, whenever possible, it should be delivered at home. And that's not a new idea, but it is even more important now than it has been in previous decades, because as more people live for longer, we need to support them to live as independently and as healthily as possible. And so I want to talk today about some of the fundamental changes and reforms that we're making to health and care services, which should help us to achieve that aim. And to do that, I'm going to look in detail at the integration of health and care services, the transformation of primary care, and the provision of specialist operations. And at the end of my remarks, I'll talk about the health and care workforce, without whom we can't do any of what I'll be talking about. And the health and care workforce, of course, is the workforce that I hope many of you in this audience will soon be joining. And I want to make some further and hugely important announcements here about how we invest in the future of the health and care workforce. Now, first to talk, I suppose, about what we would describe as the challenge. The population change that we'll face in Scotland in the coming decades is already easy for us to predict and to quantify. At the moment, there are in Scotland around 430,000 people who are aged 75 or over. By 2039, when I'll be a lot older and most of you here will still be very young, by 2039, that number will increase by 370,000. So 430,000 today, increasing by 370,000 by 2039. Now that increase, just to put that in context, that increase is roughly the same as the populations of Aberdeen and Dundee put together. Now, that trend, and this point is one that sometimes not you as students here, but many people in wider society miss. But it's a point we shouldn't miss. That trend is hugely welcome. We shouldn't see it as a burden or a challenge. We should see it as something to be welcome, because it means more of us are living longer into old age. But notwithstanding how welcome it is, it does have two very significant implications for our health and care services. And the first of those is that although the increase in average life expectancy is something we should celebrate, we can't ignore the massive inequalities that exist between different parts of our country. Those inequalities are, I think, a scar on our society. You know, here in South Musselburgh, average male life expectancy is 76, but just 4 miles away in Niddrie, it's only 58. Now, fundamentally, that's not an issue that can be fixed by health services alone. That's a consequence of deep-seated inequalities in our society. And it emphasises, and this is the first big lesson we need to draw, it emphasises the importance of our wider work and the integration of that wider work with what all of you do to tackle poverty, deliver quality affordable housing, and improve support for parents when children are in their early years, because we know good support in the early years can tackle some of these inequalities later in life better than anything else. And it also demonstrates that prevention of illness, promoting healthy lifestyles, encouraging well-being has to be at the heart of everything that we do. Whether we are making it easier for people to be active or encouraging them to stop smoking or tackling the harmful consumption of alcohol, a focus on prevention must continue to be absolutely central to everything that we do. It's essential to tackling health inequalities, but it's also the best way of helping everyone to live as healthily as possible for as long as possible, because we don't want people just to live longer. We want them to live a healthy, good quality of life for as long as possible. So that's the first point about demographic change. The second point is straightforward. As more people live longer, it will have a direct impact on where and how we deliver health and care services. The NHS in Scotland today is, in my view, a world-class service delivering world-class care. You know, just a couple of weeks ago, we saw a report from the Royal College of Emergency Medicine describing UK accident and emergency services as the best in the world and Scottish services as the best in the UK. So you can draw your own conclusion from that. Now, our accident and emergency services, of course, are not without their big challenges, but the fact they perform best in the UK is an incredible tribute to the people who work in these services. And it's reflected in public opinion. Public satisfaction across our NHS is at a historically high level. Satisfaction with GP services has also increased. But it's in the very nature of health and care services that we can always do better. We should always strive to do better, sometimes significantly better. We have to adopt new medicines and new technology. We have to adapt to a changing population, and we have to meet ever higher public expectations. And that's why from this April, we will see the most important reform, in my view, to healthcare in Scotland since the foundation of the NHS in 1948. The integration of health and social care services is something that many of you will know about as students and as professionals. But the reasons behind integration can be easily understood, I think, by almost everybody in Scotland through their own personal experience and through knowledge of family, friends, colleagues and neighbours. An increasing number of people in our country, as a result of our changing demographics, have one or more chronic conditions which need long-term management. But if they get the right care, they will only occasionally require a hospital visit or an admission to hospital. They're perfectly capable of living independently at home, but they need a little bit more support, sometimes a lot more support, in order to do that. So it's important for them that the care worker who visits them several times a week is in touch with their GP, with the pharmacist who handles their prescription, with the befriending service that they use once a week. And it's vital that if they do need to go to hospital, if they have a fall or need a minor operation, that their hospital treatment is coordinated with their care arrangements. That means they'll be able to return home as soon as they're well enough to do so, rather than remaining in hospital for longer than necessary, because all of you in your training so far, I am sure, will be well aware of the evidence that an older person admitted to hospital, the longer they stay in hospital, the more they lose their ability to live independently. So getting people who have to be in hospital, out of hospital and home as quickly as it's safe to do so is really important. And that's one of the reasons that the integration of health and care is so significant, because it's a change that recognises the reality of people's everyday experience. It ends once and for all the arbitrary distinction between health and social care, and instead it focuses on the holistic needs of the person. Now, integration by itself as a structural change to how we deliver health and social care won't guarantee better care, but it does mean that different services are more able and much more likely to work together more effectively to deliver that high quality care. And we're already seeing some encouraging progress in some areas. For example, delayed discharge has been a major priority for us. That, of course, is when people can't leave hospital because care and support arrangements aren't in place for them at home. That's bad for the patients, but it's also an expensive and wasteful for the health service itself. And in the current financial year, we've seen an 8% reduction in delayed discharge rates. Now, I should say we've still got a long way to go, but we have started to make progress because of some of the changes that are being made. But we need to do more to ensure that integration is a success. And that's why we're supporting integration with a transfer of £250 million in the financial year that's about to start from the NHS to health and social care partnerships. Half of that will help to expand capacity and reduce social care charges, and the other half will help to meet existing cost pressures faced by local authorities. And one important pressure that money will help to fund is paying the living wage to social care workers, something we're determined to implement by October of this year. Now, I think paying the living wage is the right thing to do anyway for any group of workers in any sector. But the principles at stake in the care sector, I think, are especially important. After all, Carers are essential to the quality of life, the dignity and the independence of hundreds of thousands of people. Paying the living wage is just one way, but a very important way of demonstrating that we value their expertise, their compassion and commitment. And of course, as we move towards integration, towards providing more support for people to live at home or in a homely environment, the importance of our primary care services increases even more. We already know that the next decade will present real challenges for us in recruiting GPs. Many of our current GPs are due to retire, and an increasing proportion will choose to work part-time. One of the consequences of a very welcome trend, more women going into medicine. So what we need to do is take action now to address that. And that's why we've increased the number of GP training places from 300 a year to 400. And we're trying to encourage former GPs who've perhaps left the profession to care for children or elderly relatives to come back into the profession. But perhaps more importantly than increasing the number of GPs, although that is important, we're also working to help GPs work more closely in multidisciplinary teams with pharmacists, with community nurses, social workers, physiotherapists, chiropodists, and a whole range of other allied health professionals. In some cases, that will be about co-location, developing health centres within a community that house all of these different professionals. But more frequently, it's about changing the culture of primary care to enable people to work more closely together. And last year, the Health Secretary allocated £60 million to support this change of culture and practice, and £20 million of that money is supporting the development of new approaches to care. For example, in Inverclyde, over in the west of the country, all general practices and primary care health professionals are now looking at how they share their resources and their expertise to deliver a better service for the community that they work in. One thing they're looking at is how pharmacists can better support GPs and patients, and that's something, of course, that then allows GPs to focus more on the care of people with particularly complex needs. They're also exploring improving how services such as physiotherapy are made more routinely available to patients. And the Inverclyde project, which is one of many we'll see develop across the country, potentially improves primary care services for 80,000 people. And as we move towards the new GP contract in 2017, we hope that it's going to provide really important lessons that we can then apply across the rest of the country. And it's an example of the determination that we need to have to transform primary care so that patients get the best possible care at the right time. And the better the care in the community, in our primary care services, the less often people will have to be admitted to hospital. But the importance of local care, for that reason, does also extend to key hospital services. For some procedures, quick, efficient and safe treatment does require specialised regional or national centres. And often that will be because of the highly specialised nature of the treatment in question. Indeed, we've already moved to having regional cancer services so that we're pooling the specialism available to give people access to the best possible cancer care. But, you know, sometimes the case for having specialist centres will also derive from the sheer volume of procedures that need to be carried out. Many operations, very common operations like cataract removals or knee and hip replacements, make an enormous difference to people's quality of life, even although they're not addressing life-threatening conditions. And as the population ages in the way that I've already talked about, the demand for these procedures is going to grow and grow. We're going to see over the next few years people living long enough not just to require one hip replacement, but to require perhaps 2 or more hip replacements in the course of their lifetime. So for these elective procedures that don't arise as a result of emergencies and which can be scheduled a bit in advance, it makes sense to have dedicated facilities. It means that a patient's hip replacement is less likely to be cancelled because an emergency takes priority. And the Golden Jubilee Hospital in Clydebank is the shining example of this approach. It's been an outstanding success. It carries out 20,000 procedures a year, including hip replacements, cataract removals and knee replacements. And by doing that, it provides a service that is making a huge difference to the quality of life of many older people. And because scheduled services are provided in a separate facility from emergency treatments, people aren't subject to delays when unscheduled operations are urgently needed. And as a result, the Golden Jubilee has directly contributed to the situation we now see in Scotland, where for almost all types of elective treatment, waiting times here are shorter than they are anywhere else in the UK. So that's why we've taken the decision to undertake another of the big reforms that I want to talk about today. We've committed as a government to invest £200 million over the next few years in creating 5 new diagnostic and treatment centres around the country. Diagnostic and treatment centres that emulate in other parts of the country what the Golden Jubilee is already doing, because we want to build on its success for elective procedures. And a key point is that for some procedures, specialist centres aren't just quicker, although they are, but they're also likely to be safer. You know, we've got evidence from the United States that suggests that surgeons who do hip replacements should perform at least 35 of them a year to make sure their skills are of the required standard. And that's easier to achieve in dedicated specialist facilities. And that emphasis on expertise and quality is why we'll continue to plan treatment for other conditions like vascular disease and cancer on a regional or a national basis. It's also why we have managed to improve the treatment of acute heart attacks when a few years ago we concentrated treatment in a smaller number of more specialised centres. For some complex procedures, that's the best way to provide better and safer care. But although patients will often need to have surgery and complex treatment in special centres, they don't need usually to have their follow-up care in these facilities, which brings us right back to what's at the centre of my remarks today, the importance and the primacy of community care. The majority of support that a surgical patient will require can be delivered much, much more locally. And that's why we need to plan for specialist services to be delivered by networks of hospitals. People might spend time in a major centre of expertise for their procedure where it's essential to get the best treatment, but the subsequent support they get will be in their local hospital or at their GP surgery, through rehabilitation services, home visitors or telehealth services. The best healthcare in the future, and this is what we're trying to achieve through the reforms I'm talking about, the best healthcare will combine specialist expertise with local accessibility. And of course, as we work towards this vision of health and care services working much more closely together, of as much care as possible being delivered locally with specialist services where we need them, we need to value and support our health and care workers perhaps more than we've ever done before. And we need to make sure that we are training the right numbers of professionals in and across different specialties with the skills that they need, the skills you need for the health service of the future. We've already invested heavily in the health and care workforce in the last 9 years. The NHS Scotland workforce has increased by more than 10,000 since 2007. I've already mentioned a couple of additional steps that we're taking, funding more GP training places and paying the living wage to care workers. Today, I want to make some additional commitments. Our approach to student support, alongside our commitment to free tuition fees for students in Scotland, of course contrasts very starkly with recent decisions taken by the UK Government. The UK Government has decided to remove free nursing tuition and nursing bursaries. I want to tell you today that the Scottish Government is absolutely committed to retaining a nursing bursary. We recognise the demands on student nurses and midwives, and we understand the importance of your role. So to make sure that we in the future are well placed to attract the best young people from all backgrounds into our nursing workforce, I'm making a clear commitment today that we will retain free tuition for nurses and we will also retain a nursing bursary in Scotland. 3 days ago, we also launched a major campaign to encourage junior doctors to come and train here in Scotland. That campaign stresses the quality of the opportunities available here, but it also emphasises the value people in Scotland attach to the role and the work of junior doctors. And on a day when junior doctors elsewhere in the UK are on strike, it's perhaps important for me to stress the value that the Scottish Government attaches to the work that junior doctors do. So I hope we see many junior doctors in Scotland across the UK and from elsewhere see Scotland as a great place to come, do their training and then to work. But it's also very clear that if we're going to recruit the best possible workforce for health and social care services, we need to recruit from the widest possible talent pool. I know this university does great work in widening access and encouraging and enabling people from all backgrounds to come here and take advantage of the world-class education that is delivered here. But we need to do more in other universities across our country. You know, right now, only 1 in 20 new doctors come from the most disadvantaged areas of our country. If we had truly equal access to the medical profession, that figure would be 1 in 5, but it's only 1 in 20. Now, that's not a reflection on the talent or the aptitude of students from disadvantaged areas. It is an indication of how disadvantage acts as a barrier to equal opportunity. Now, that's bad for individuals who are denied a fair chance to enter a good career, but it's also bad for our society as a whole because we're losing out on too many of the talented and dedicated medics of the future. So that's why we're confirming today a number of measures to widen access to our medical schools. We're going to introduce a new entry-level programme available to help secondary school students from deprived backgrounds prepare more effectively for undergraduate medical education. And we're also taking the step of increasing the number of medical student places by 50 from this August. And the importance of widening access to medical degrees will be a key priority as these extra places in our medical schools are filled. And finally, we'll be launching Scotland's first graduate entry programme for medical students. That programme will include an offer to pay fees, but that offer to pay fees will be conditional on students agreeing to enter the NHS Scotland workforce when they qualify. It's a further way of ensuring that financial concerns don't deter talented graduates from studying and working in medicine, but it's also a way of ensuring that we retain the best talent to work here in our NHS in Scotland. The other announcement I want to make relates to the nursing profession. I spoke earlier about the importance of reforming primary care, of ensuring that carers, GPs, nurses, pharmacists, allied health professionals and the voluntary sector, which I've not mentioned so far, all work closely together. Multidisciplinary working, long talked about, must now become a reality like never before in the health and social care services of tomorrow. And nurses, in my view, have an absolutely crucial part to play in this. That's why we've already provided funding for additional health visitors, and we're now looking at other nursing roles. For example, we want community nurses to be senior decision makers within our healthcare teams. Nurses are ideally placed to lead care for those with complex needs, such as the frail elderly or those needing end-of-life care. And by doing that, they can help people to live as independently as possible for as long as possible and prevent unplanned admissions to hospital. Advanced nurse practitioners are also hugely important. Advanced nurse practitioners already work closely with GPs and with district nurses and other professionals, but they potentially in the future have a major role to play in assessing, treating and diagnosing people in the community during the day and out of hours. And by doing that, they can help provide better primary care for individuals and help us in doing what I spoke about earlier on, further tackling delayed discharge rates. That's why I can confirm to you today that we're going to fund the training of a further 500 advanced nurse practitioners. The nursing profession in Scotland has a long and a very proud tradition, and it's one that is firmly rooted in enduring values of care, compassion and professionalism. So I think by investing in training, we'll ensure that nurses continue to play a hugely important role, but an ever more important role in the future, applying those enduring values in the health and care service of the future. So these are the initiatives we want to take to make sure that we are planning for a health and care service that is fit for today, but more importantly, fit for the future. You know, this year sees the 70th anniversary of the introduction of the legislation which created the NHS in Scotland. The first people to be born under NHS care are now in their late 60s. And my hope, I think the hope of every single one of us, is that in the years and decades ahead, is that as that generation enters their 70s and then their 80s and hopefully their 90s and even beyond, they'll again benefit from transformational change in our healthcare system, that the integration of care and health services will help that generation to live independently, healthily and happily for as long as possible. But equally, I hope that the decisions we take today will ensure that babies born now will be celebrating our National Health and Social Care Service when they are in their 60s, 70s, 80s, 90s, and definitely by that time, their hundreds as well. My firm belief is that the reforms we are implementing across our health and care services will benefit everyone in Scotland. They'll build on the success of our current healthcare system, and for all the challenges that it faces on a day-to-day basis, our healthcare system is a success. And these reforms will ensure that services are delivered as locally as possible and in a way that meets people's needs as individuals, not as statistics or numbers or faceless patients, but as people, as individuals. We need personalised care to match the personalised medicine that I spoke about earlier. And if we succeed in that, we will help to reduce inequality and we will improve health and well-being and the experience of healthcare for everyone. Many of you in this room, as you go on to take up careers in different branches of healthcare, will be absolutely central to achieving our vision for health and care services in the years ahead. I get the easy part. I get to stand here and tell you about it. Shona and I get to plan the policy that will make it possible. It's all of you who will deliver it in our communities, in our surgeries, in our hospitals right across the country. So my commitment to you is that this government will continue to value your compassion, commitment and professionalism that is demonstrated on a daily basis by health professionals across our country. And I hope, as today's announcements demonstrate, we'll continue to invest to help you do your job to the best of your ability, because we know that by doing that, we can create the health and care services that people across Scotland deserve and need. And we can then continue to make important progress towards becoming that healthier, happier and fairer nation. Thank you very much indeed.